The gynecological scan, 20 years ago, we used to do it by abdomen, then we did it transvaginally, and a gynecological scan was just a gynae scan. We had to look at anatomy. Now we divide it into the fertility scan, the early pregnancy scan, the general investigations of menorrhagia, pelvic pain, and other symptoms that women may have, and the diagnosis and screening for ovarian and endometrial cancer. And somebody doing a gynecological scanning should be able to work out the difference between a malignant tumor and a benign tumor. Well, we usually do it correctly. Here you see irregular angiogenesis, and this is very regular angiogenesis that you get in benign tumors. And somebody doing a gynecological scan should be able to tell the difference between a hemorrhagic cyst and an endometriotic cyst. But that's the gynecological scan. Oops, my children always say I've got a very loud voice. I'm embarrassingly loud, so, but I can see I have to use this. So that's the gynecological scan. But a person doing a fertility scan would immediately do Doppler around this hemorrhagic cyst, and he would realize there was high flow, low resistance flow, and he would say, that's almost certainly a luteinized unruptured follicle, and he would say to the woman, well, this happens in every woman from time to time, and it's of no great significance, and it will go away. So that's the fertility scanner. He's giving extra information. And the fertility scanner would say, yes, you've got an endometriotic cyst, but you've got normal ovarian tissue to the side with a few follicles there, and therefore he would advise her about her fertility potential, and maybe she would have treatment before anybody tried to remove that cyst. Too many women are rushed to surgery with no thought given as to their future fertility. This happens all the time. So the fertility scan is a mindset. It is, when you do that gynecological scan, you say, what about this woman's fertility potential? Is she wanting a baby? How can I help her achieve that? Okay. So when you do a fertility scan, you can spend £50,000 or so on a high quality machine with Doppler, 3D, 4D, all and high resolution, or you can buy a simple sort of computer-style ultrasound machine with Doppler costing £6,600. You've got the choice. What I want to convince you today is that you should spend £50,000. I have no shares in the company. So the transvaginal scan, this is fairly standard for anybody doing transvaginal scan. I just want to focus on two things. There should be minimal embarrassment or discomfort. It's a very intimate exam. The person doing this examination should be very sensitive to the woman's feelings of being very exposed. And so it should be done in a very sensitive way. The other thing is the patient must be involved in the procedure. There's nothing worse than a woman lying, her legs apart, somebody doing this scan, not talking, not seeing the image on the screen, a few, oh, it's a difficult scan or something, and then she gets up, and then she says, what did you find? And she says, oh, well, let your doctor know. That is absolutely hopeless. What the person should do is turn the screen and show the woman every part of that scan that they're doing. Every follicle that's measured, she should see that follicle being measured. When you're doing blood flow in the stroma, she should see that. And you should explain to her what's happening. Involvement in the procedure is one of the great advantages of ultrasound. It's a patient-friendly technique, the acceptable face of technology. The fertility scan means the assessment of ovarian reserve, assessment of polycystic ovaries, follicular development, uterine receptivity and cavity assessment, ovarian endometrial synchrony, corpus luteum development, cysts and tumors, and tubal patency. I'm not going to deal with all of these. I just want to highlight some of the important things that we do. Here, this is the transducer in the vagina, and you will not only look at the uterus, the tube, if you have contrast, and the ovaries, but you will actually study the blood vessels supplying the uterus and actually the vessels inside the ovary, not the vessels in the infundibular pelvic ligament, which used to be done unsuccessfully, but within the ovary itself. Although you can find the ovary, sometimes it's difficult to find by tracing out the tubal vessels until you find the ovary. New ultrasound techniques, I mean, the manufacturers keep thinking up new ideas to sell machines. One is 3D volume and vascularity measurements called vocal, and the other is automatical follicle count and measurement. Here you can see, instead of measuring 3 diameters and multiplying by a constant to get the volume, you can actually trace round, and the machine automatically will calculate the volume of the ovary. And it's very reproducible. So if you want to measure the volume of the ovary, which is quite important in fertility work, it's much more exact with vocal and using these 30 degrees rotational movements. And then using the same vocal technique, the machine can count up all the colored spots inside the ovary and work out the vascularization index. That's the number of color voxels as a percentage over all the grayscale parts of the ovary. So the vascularization index tells you about the number of vessels in the ovary. And the flow index weights the strength of the signal and will give you some idea of the strength of flow. And you can have a combination of the two called the vascularization flow index. That's a new thing. Again, as you'll hear in the rest of my talk, I don't have great faith in it. It's too susceptible to problems of shadowing, of gain, inconstancy. If you turn up the gain, you get more signals, and so on. And that's it, working out the spectrum of color signals and grayscale signals. And it will, with our inversion techniques, show you very quickly all the follicles in a, not in a negative image, but in a positive image. And it will also color all the follicles so that you can get a very accurate measurement of the 3 diameters and the volume of each of the follicles. The trouble is, it's a little bit time consuming. It sometimes colors in follicles that aren't really follicles. It sometimes misses follicles, so you have to go back and check it and remove the follicles that are not follicles and add in follicles that were missed. So it's time consuming, and many people, even though it's very attractive looking, can't be bothered with that and just do it in the good old-fashioned way. Gita Nargan, when she was at St. George's, worked out the one-stop fertility assessment. She was tired of women coming to the antenatal clinic, not the antenatal clinic, the gynecological clinic for her fertility investigation, having been to the GP and having investigations done over 6 months, sometimes a year. The investigations were repeated many times. They were done in the wrong order. And all this time, the woman's fertility was decreasing. So she worked out the 1-hour visit where there was an initial consultation, a detailed pelvic scan, an examination of the fallopian tubes, blood test for AMH, detailed semen analysis, and then at the end of this 1-hour consultation, 1-hour investigation, a final consultation. So she was sent away with a lot of information about her fertility status. Now, this is not a means of rushing somebody into IVF. One of the great features of our clinic and her practice always has been, if we can solve this woman's fertility problems naturally, that's the way we're going to do. If we can give advice on lifestyle, like we heard from Rennie Friedman, then that's what we should do. But of course, a lot of people refer to our clinic now are older, and so IVF is the logical way to treat them. I'm not going to talk about examination of the fallopian tubes, but now with 3D ultrasound, and again, this is a test that we actually first developed, we're the first people to develop at St. George's Hospital with Povilas Sladovicius, but you can now see the uterine cavity and the fallopian tubes with 3D ultrasound. So we are now moving away from the typical hysterosalpingogram where a woman went to an X-ray department, met somebody she never knew, who was really bored with the whole procedure, and it was a pretty traumatic procedure. Now they're being examined by the team that they know and love, and they can get just as good information about the fallopian tubes and the spillage. I want to say something about predicting ovarian reserve. Ovarian reserve represents the remaining population of primordial and resting follicles. That's the official definition. But very often in the literature, ovarian responsiveness is counted as a test of ovarian reserve. And the ovarian reserve can be defined as the number of antral follicles that can be stimulated into dominant follicle growth by exogenous FSH with conventional stimulation. And the number, they say, should be 8 to 10, and a low reserve is less than 4. That's a rather artificial definition of low ovarian reserve, but it's an easy one to do studies for. The tests that are usually done in terms of biochemical tests, FSH, which is increasingly distrusted because it fluctuates so much, inhibin B, which has gone out of fashion, and anti-Müllerian hormone is the main one. It's produced by the granulosa cells of the small follicles, less than 6 millimeters. It has constant levels during the menstrual cycle, consistent with continuous non-cyclic growth of small follicles, so it can be done at any stage of the cycle. AMH has become the leading biochemical estimate of ovarian reserve. And there is a correlation between the stock of primordial follicles and the small growing follicles. In terms of ultrasound markers, there's ovarian volume, which has fallen out of fashion, but less than 3 ml volume is definitely indicative of a low reserve. Ovarian stromal velocity, I want to say a few words about that. It's very popular with my group because we invented this, but it's not used much by other units. I want to explore that a little bit. The VI and the VFI, these vascular indices, have not been shown to be useful. And the antral follicle count shows a good correlation between small follicle count and primordial pool, and AFC should be the first choice. This is Hendricks in 2005. So antral follicle count is the main one. So we're left with these two tests, which you've seen this slide before. This is the antral follicle count, and you notice how by the time you get to 35, it begins to fall quite sharply, which is the accepted trend in all research done in this area in terms of the number of eggs in the ovary. And the AMH, anti-Müllerian hormone, similarly at 35 begins to fall quite sharply. But the thing I want to point out is that right from an early stage, about 5% of women have a remarkably low antral follicle count by the time they get to the age of 30, and the same with AMH. Some women have low AMH from an early stage. I would say at least 10 to 15% of women. And really the concept of a woman who hasn't had a child coming up for a test at the age of 30 to see what her AMH is, to see what her antral follicle count is, so that she has the option of freezing, seems to be a very sensible thing to pursue. I think we should recommend that women have a test of their ovarian reserve if they're considering having a baby. So this is what we're seeing with the antral follicle count. Really, they're appearing in the second cycle before. Remember that during the ovulatory cycle, the follicles in the ovulatory cycle have been growing for two previous cycles before this. The AMH is secreted by the early antral follicles, okay? And this is what we're seeing with the antral follicle count. So we're seeing them a little bit later with ultrasound, but in the cycle before the ovulatory cycle. Okay? They're both indicative of the pool of eggs in the ovary. These are the resting eggs here in the ovary. This is an ultrasound slide of a normal antral follicle count. There's the ovary, and you count up the little black circles, and 1, 2, 3, 4, 5, 6. 6 there. There may be one on another plane, maybe 7. 7 on the other side, 14. That's a good antral follicle count. She would be suitable for mild IVF, stimulation on day 2. This, you can only see one follicle. There may be another one on a different plane, and there may be one on the other side, but 3 antral follicles, that's a low reserve. Notice how we look at the stromal flow as well, the flow within the substance of the ovary. This normal antral follicle count has 13 centimeters per second peak systolic normal stromal flow. So, normal stromal flow, normal antral follicle count, she is absolutely ideal for mild stimulation from day 2. Whereas, this lady we should probably treat with a natural modified cycle. Let the follicle develop for 5 days before we start to treat her, before we start to encourage that follicle to grow. Because there's low stromal flow here at this stage. So it's only 6 centimeters per second. Now this is a polycystic ovary, and you can see there's a large number of follicles surrounding here. Certainly more than 12. That's the recommended definition. And you can see the stromal flow here is very high on day 3, 37 centimeters per second. That's a really high stromal flow. We can tell on day 3 that this lady, if she's going to have IVF, is going to respond very rapidly to stimulation, possibly excessively, so we have to be very careful. We give a very low stimulatory dose, okay? So we're warned well in advance. That's the advantage of doing stromal flow in the ovary. You're warned well in advance of what's going to happen, whether it's going to be under response or over response. This is the woman with multifollicular ovaries. She's not got polycystic ovary syndrome. Why? Because the stromal velocities are normal, 11 centimeters per second. So I know this woman is not going to over-respond to a stimulation. So stromal flow is very important, but notice how I'm measuring the velocity. It's the velocity, not the resistance to flow, and certainly not the vascularity index. This was a paper way back in 1998 we wrote showing how polycystic ovarian syndrome and also polycystic ovaries without the syndrome have a high stromal velocity compared with normal velocity. This is average of 15, but really we're very concerned if it's over 15 that this is going to be a very high responder. I just want to say something else about stromal flow, is that you have to zoom the ovary up till it fills the screen. So when people do stromal flow, sometimes I think that they use a small picture of the ovary. You have to zoom it right up, and then you look for these small vessels within the stroma. This would be picked up by the vascularity index. This is used for velocity. You can see the high velocity there. This is a woman actually with very few follicles, and the systolic velocity is low, but you can see the bright up there from the artery there. Okay, so that's how we do it. Sometimes you'll see a woman with no follicles in either ovary. Don't jump to conclusions that she's no follicles, because when I started to do stromal flow, I found high resistance and low systolic velocities in this ovary, but when I went to this ovary, there was actually very good velocities. The peak velocity was over 15 centimeters per second. And I said to myself, how possibly could we have good stromal velocities here? So I zoomed up on it, and then I put on the color Doppler, and what do you see? There's a little circle there, and that is persisting corpus luteum in this ovary. And persisting corpus lutea are not associated with good recruitment. They inhibit recruitment of the follicles. So we can afford either to wait in this cycle or try again the next cycle. We shouldn't write this off. There may be a delay because she's got low reserve, but we shouldn't assume. So that's that she's got no follicular growth. So that's the importance of doing Doppler. Every time you do a scan, you should be doing Doppler. Why? Because it tells you about function. It's all right imaging, doing grayscale imaging, that's useful, but Doppler tells you about function. We need to know about function. This is a study by Nick Rain-Fenning's group, and he compared AMH, FSH, mean ovarian volume, and total antral follicle count in predicting poor responders. And here you can see that the best was antral follicle count, and the next was AMH, and the others were very poor. And so we accept that. But what he also showed was that the mean vascularity index and flow index and vascularity flow index were very poor at predicting ovarian reserve. But that's because he was using the wrong technique. You've got to use velocity. It's the only thing that works. Okay, well, you know about the prevalence of PCO and PCOS, but PCOS is 6 to 8% of the population, and PCO is 22 to 24%. And that's the official definition in the Rotterdam Conference. And a follicle number more than 12 per ovary, and ovarian volume more than 10 ml is a definition of polycystic ovary. Now, predicting ovarian hyperstimulation, these are old slides. They were taken at a time when we used to downregulate. The only cases we ever downregulated, Mrs. Nargan downregulated, was the PCO cases. We don't downregulate PCOS women now, but this was day 7 after a downregulation bleed, and look at the stromal flow here. Now these are the follicles in this case, massive stromal flow in the middle here. Look at the high velocities. I can't see it from here, but there's something like 29 centimeters per second. So day 7 after a downreg bleed, you've got these very high stromal velocities. You know this woman is very likely to get ovarian hyperstimulation syndrome unless you take appropriate action. This is a lady day 6 of the cycle after a downreg bleed. And look at the stromal flow. I've isolated it out here, but you can see it here, right in the middle of the ovary. So again, Doppler is very sensitive to the ability of the ovary to respond to stimulation, and that's why we should always use it. Now, from day 7, you're beginning to see the development of the dominant follicle. And when you see perifollicular flow round the follicle, then you know that that oocyte should be mature, because with a velocity of more than 10 centimeters per second, because you can tell, I mean, it's very easy to take a stromal vessel and think it's a perifollicular vessel. So you have to see it encircling the follicle, but also bulging into the dark space here. So perifollicular flow has to be done intelligently. But if you do it in 3 dimensions, you can see all of the vessels. So you can see they're completely circling this follicle. You don't always get it in a single slice. But we pay a lot of attention to perifollicular flow. It will help us decide when to trigger. If we find a follicle that may be 17 or 18 millimeters, but there's no perifollicular flow, we may not trigger at that time. We may wait for perifollicular flow to develop, because we're not dealing with a lot of follicles. Some people eyeball it, which is fine. I mean, it's better to do the actual velocity round, but if you find that the flow occupies more than 75%, this is from Robson, then you've got a much better chance of getting a higher pregnancy rate in the embryo transfer cohort. And the velocity increases with the administration of HCG. And you can see how angiogenesis increased dramatically with HCG. And these are the velocities round a follicle. This is an old study that I did many years ago. And Gita Nargant has shown from her work at King's that follicles with a good blood velocity, more than 10 centimeters per second, yield good oocytes. And HCG administration increases follicular velocity, and follicular VEGF levels correlate with vascularity. And follicles with good perifollicular flow are associated with conception. So looking at perifollicular flow is important. Here's a case I saw just 2 days ago. She is day 9 of her cycle. She has a 15 millimeter follicle. In fact, she has one on the left and one on the right, exactly the same size and exactly looking at this. There's a good endometrial thickness of 7 millimeters, and look at the flow around this follicle. Now, Gita has always said, with natural modified cycles, you don't need to wait till the follicle is 17 millimeters. We must get away with a number for the diameter of the follicle to say that the oocyte is likely to be mature. This oocyte will be mature. And there was perifollicular flow around the one on the other side as well. I didn't want to crowd the slide. So the vascularity around the follicle is taking over from just a size in terms of deciding when to trigger ovulation. There's another thing I'm doing at the moment, of course, is looking at the follicular wall in 3D, and that's only twice magnified, but you can see the vessels in the follicular wall here. And if I zoom right up, so that this is a 15 millimeter follicle, but if I zoom right up, and it's magnified 5 times, then you can see the individual capillaries in the follicular wall. And I count them, and the median number of ripples, which is capillaries per centimeter, is 19. And the range is 17 to 22. By the time you get to a 22 millimeter follicle, then the capillaries begin to break up. And I suspect that's a precursor of ovulation. And you can see dysfunctional follicles. This is a follicle. But how do I know it's dysfunctional? Because there's not a nice regular ripple effect on the wall of the follicle, and there's an adhesion across the follicle here, but it's like a stormy sea. So you're not having a nice ripple effect, it's a stormy sea effect. And I often wonder when I see a follicle, and it's the little projection in the follicle, does that mean it's not a very good follicle? We see it quite often. Well, when you do it in 3D, you can see it's just a fold. And here's one with several little projections. See them there? I don't know what you'd think when you're scanning, but would you worry about this follicle? Well, here it is. It's just a series of folds across the follicle. But as long as you get a good ripple effect, in fact, it's a perfectly good follicle, and it's not a bad sign. But this is what 3D is helping us do, kind of look inside the follicle and find out what's happening. And you will see in the literature occasionally a paper which says that that is a cumulus. Well, I actually don't believe. I would love to be able to see an expanded cumulus, because that would really tell us that it was time to trigger ovulation. But this is the 3D picture, and it does look suspiciously like a cumulus. But you don't often see it, so I have to reserve judgment on this. But I would love all the chaps in our clinic who are doing egg collection to look seriously for the cumulus when they're doing an egg collection, just to see if we can see this sort of feature. But anyway, that's what you see with the cumulus. And then, of course, the ripple effect can distinguish a follicle from a cyst. Here's a large follicle with little follicles around it, and you can see the ripple effect here. That's only twice magnified. And here's a cyst. How would you know a cyst from a follicle? Because it's got a smooth wall. The cyst is a smooth wall. So it's very useful in many ways. This was a follicle. You can see the nice ripple effect. This we thought was a follicle. But when I did a 3D, it turned out to be hydrosalpinx. So it's helping, if you do a 3D, when you're doing a follicle count or tracking the follicles, then it's very useful. Implantation. Right, ultrasound markers of uterine receptivity. Endometrial thickness and volume. Everybody works on endometrial thickness. More than 7 millimeters is acceptable. Endometrial morphology, triple layer, is strongly predictive of implantation. Yes, these are the two key ones, okay? Subendometrial contractions. I look at them all the time, and I wish we could find an easy way to measure subendometrial contractions, because They definitely indicate to me receptivity of the endometrium. Uterine artery PI is very important. I'm going to go through that with you. A high uterine artery PI is indicates reduced receptivity. It's only a bit, there's no gradation. I mean, you know, a PI of 2 is not more predictive of implantation than, say, 2.5 or 2.8. But more than 3, or between 3 and 3.5, or more, indicates reduced receptivity. And endometrial flow, I think it's something we should all do to look at endometrial and subendometrial flow. So all of these are ultrasound markers of receptivity. Well, you know that these are the typical patterns of the endometrium. I won't dwell on that. There's early proliferative, that's late proliferative with mucus in the cervix. It's always a good sign. Periovulatory with a thick endometrium, triple layer, that's a very good sign. It's early secretory. You see the clouding that comes over with the rise of progesterone, and late secretory where it's a very white endometrium. Okay, you've seen that slide. But the reason I showed that slide again is the uterine artery. We put a gate on the signals from the uterine artery, and we're always at a low angle to the uterine artery because it's at a low angle to the probe. And this is the kind of picture we see from the uterine artery. That's a normal uterine artery waveform with lots of diastolic flow, and that's the peak systolic part. But if you see a waveform like this, where there's reverse flow in diastole, all throughout diastole is below the line, and the PI is 1.12. No, it has to be about 5. Sorry. I'm reading it wrong. That's the RI. PI is 10.38, yeah. So that is a very, very high PI. You would not put embryos back here. So if you see a picture like that, before, at the time of say, the trigger for ovulation or embryo transfer, you would not put the embryos back. That is a no-no, because the embryo will not implant with a uterine artery like that. How many people look at uterine artery PI in an IVF cycle? Not many, but you should always do it. And it's very often, this picture is often associated with polycystic ovarian syndrome, and whether it's anything to do with high androgens, I just don't know. And then normal subendometrial flow. Here's the spiral arteries. These are the spiral arteries in color Doppler coming into the endometrium on day 8, but they're not penetrating into the endometrium. When you see it on day 12, you see these vessels penetrating right into the endometrium. That's a triple layer endometrium. It's perfect. Here you see the vessels going right into the inside of the endometrial layer. That's a very good sign of receptivity. So uterine artery and subendometrial flow. So here we see the perfect picture. Nice 3D picture of the uterus, good subendometrial flow and endometrial flow, good flow around the follicle, good uterine artery, good flow in the perifollicular flow here, 11 centimeters per second. The perfect scenario. We hope, we expect, this woman has a very high chance of succeeding. Factors which may inhibit implantation. Submucous fibroids, endometrial polyps, adenomyosis, vascular abnormalities, intracavitary adhesions, endometrial calcification, intracavitary fluid, and poorly vascularized coprocitium. I'm going to deal with most of these, not all. You mustn't forget, though, and this is a slide that Geeta showed in a tabular form, but with donor eggs, and this is from the assisted reproductive technology success rates from the American Society for Reproductive Medicine, that you have a constant of around 50% throughout the range of ages of the woman, whereas with her own eggs, it falls very dramatically. So the biggest factor, of course, of poor implantation is the quality of the egg. We accept that. But if you see polyps in the endometrium, especially if there's a feeding vessel, then this polyp will have to be removed. Anything over 5 millimeters should be removed, and even if it's less than 5 millimeters, if it looks very vascular, I think it should be removed. This is a lady with recurrent failure of implantation who came to us when we were at St. George's, and I did a scan, and all I could see was this little circle here. But apart from that, I thought it might be a little fibroid. But my rule always is, press the colour button, find out what the flow is like, function. So there was it there, put on the colour, and look at that massive blood vessels surrounding this little dark circle with high velocity flow. So this is an AV malformation. It was eventually embolized, this AV malformation. So this is very important. You have to recognize things because that will cause failure of implantation of the embryo. So you have to exhaust everything, and ultrasound is really very helpful in achieving that. Fibroids is a major cause of failure of implantation. And even very small fibroids that only deviate the endometrium a little bit, submucous fibroids, are very, very important in causing failure of implantation. And here we put on the colour, and you see this circle of colour here surrounding this fibroid. That circle of colour means increased flow, but it doesn't mean it's an increased chance of implantation. It's the wrong kind of flow. And also it means that the fibroid is going to grow with all that vascularity, so it has to be removed by hysteroscopic surgery. Here's another one, just the same. A submucous fibroid, and when we look at it in 3D, here's the fibroid occupying, as I say to the woman, occupying the baby's space, so it has to go. And sometimes you see a polyp, and you think, oh, that's a simple polyp, but if you use the right algorithm, you can see that this is a fundal submucous fibroid occupying the top of the uterus here. So that has to be removed as well. And this is an anecdotal case which I found very interesting, but I saw this lady early on in her cycle, and there was a big fibroid, and I thought, we'll never get the catheter past this to an embryo transfer. I saw her a few days later, and that was the fibroid. It looked a little bit less coherent, spread out. And then I saw her after 8 days, and the fibroid had significantly disappeared, and you could easily get the catheter past this. But it's just very interesting that a fibroid can change over the course of a cycle very easily. Should you do hydrosonography? Yes, I think it helps enormously, and I think if you do see submucous fibroids, hydrosonography is helpful because you can outline the fibroids, submucous fibroids very clearly, and this helps the hysteroscopic operation. Now, here's a large fibroid here, but there's the endometrium. We do a 3D, and there's the 3D endometrium. So it's actually quite a straight endometrium and is suitable for implantation. So although there's a big intramural fibroid, I think we can proceed with IVF without removing it. You must reduce the amount of unnecessary surgery that a woman goes through. True, an intramural fibroid will reduce her chances maybe about 20%. But even so, depends on her age, but it could be a good decision just to go ahead with IVF, because actually removing a fibroid sometimes disrupts the uterus and the endometrium. So I think it's probably a good idea to go ahead. Whereas this one is a very vascular fibroid. We're worrying about sarcoma, and so that has to be removed. This is just one of the many meta-analyses on fibroids, but you can see the intramural fibroids reduce it by about 20%, but of course submucosal reduce it by 70% the chances of a pregnancy rate, clinical pregnancy. So it's the submucosal that are our main target when we're doing ultrasound. How about adenomyosis? Well, this is an adenomyotic uterus. First of all, it was the junctional zone, just underneath the edge of the endometrium, surrounding the endometrium, was first diagnosed by MRI, and it was the radiologist that really defined what the junctional zone was, and they said it was between 5 and 12 millimeters, and here's a lot of cervical cysts. And the junctional zone is the subendometrial compartment of the endometrium. It's derived, like the endometrium, from the paramesonephric ducts, unlike the outer myometrium. It demonstrates a cyclic pattern of estrogen progesterone receptor expression. It undergoes cyclic changes in thickness. It undergoes rhythmic contractions, 3 per minute, amplitude 1 millimeter, usually from the cervix to the fundus. And its functional role is in sperm transport, implantation, and hemostasis at menstruation. I made a point of mentioning this because I think too often we ignore the junctional zone in our, it's associated with fibroids, it's associated with adenomyosis. This junctional zone dysfunction is believed to be associated with impaired sperm transport, failure of implantation, placentation, dysmenorrhea, and endometriosis. I think it's very underdiagnosed. These are MRI scans showing gross adenomyosis. But we can see it by ultrasound. First of all, you have to get a nice 3D image of the uterus, and if you put on gradient light algorithm and put a high threshold, you can actually see the junctional zone very clearly here surrounding the uterus. You can see the junctional zone there. And this was taken by Hippocrates just the other day, and I thought, well, it's too good a picture not to show you, because you can see the endometrium there in a coronal view, and you can see the tubes coming out there, and that's a beautiful picture. He gets it every time. This is adenomyosis by 2D ultrasound. Now that's quite gross. Good triple layer endometrium, but still. And you can see the endometrium moving in. You've got a loss of the junctional zone. That beautiful junctional zone I showed you before is gone. And you can see the endometrium streaming out into the muscle. Here's another case. You wouldn't guess there was gross adenomyosis here. There's the endometrium here. But when we do a 3D scan, look at the endometrium streaming out into the muscle and occupying the junctional zone here. See that solid lump of adenomyotic tissue right in the junctional zone. So with 3D ultrasound, it's simple, quick, easy. You don't need an MRI scan to diagnose adenomyosis. And it's time we did a major study looking at, because I find it a very common finding in an infertility clinic. There must be an association between this sort of picture and infertility, because you wouldn't find it in a family planning clinic if you're doing scans there. So I think it's a major cause of failure of implantation. This is a woman who had hysteroscopic surgery for an arcuate uterus, and I don't think they did her any good, because look at the adenomyosis streaming out into the junctional zone and beyond there. The other thing with 3D scan of the uterus, because you get the coronal view, you get a much better idea of congenital abnormalities. These are the classic ones. Arcuate uterus, where you've got this, yeah, no, I'm just trying to think, obtuse, an obtuse angle, sorry. I'm being obtuse. This is an obtuse angle of the fundus dipping down here, causing a heart-shaped uterus. This is a subseptate where you've got an acute angle of the septum dividing the cavity here. This is a unicornate uterus. This is a bicornate uterus where there's a dip in the myometrium. And this is a uterus didelphys where you've got two separate uteruses. Well, you can see them all with 3D ultrasound. This is a uterus didelphys, two separate uteruses, two separate cervices. This is a unicornate uterus. And if I showed you the 2D picture, you'd never have guessed it was a unicornate uterus. It just looked like an ordinary uterus. This is a subseptate because of this acute angle here, okay? And this is an arcuate uterus because you've got an obtuse angle a wide, more than 90-degree angle, whereas this is a less than 90-degree angle. So you can divide them up. And these are the studies that have been done in this meta-analysis. And I think it's very useful to make a note of this. In terms of arcuate subseptate, septate, bicornuate, didelphys, and unicornuate, there's no effect on conception. That's the first thing you've got to remember. So these type of uteruses don't affect conception. I'm nearly finished. First trimester miscarriage is the subseptate and the septate uteruses. So a septum is a big cause of early miscarriage. Arcuate is a major cause of second trimester miscarriage. And preterm birth is associated with most of these abnormalities, and malpresentation at delivery with most of the abnormalities. So it is important to inform the woman when you've done this scan if she's got an abnormality of the uterus, because it can affect the pregnancy but not conception. Fluid in the endometrium is a little bit of an obsession with mine. Here's fluid in the endometrium associated with dehiscence of the cesarean section scar. And this lady had multiple failed embryo transfers elsewhere. She came to us and we found this, and so she had an operation to close her scar off. It's also associated with hydrosalpinx. 3D ultrasound shows the hydrosalpinx brilliantly. You can have no doubt that this is a hydrosalpinx. And you see the fluid in there. So this has to be clipped. Endometrial fluid is also associated with intrauterine adhesions. Here's a little pool of fluid in the fundus. So, and you see it's a thin endometrium, and there are adhesions in this when we zoom up. So, we have to attend to this. So, conclusions. The fertility scan is important for assessing ovarian reserve, ovarian responsiveness, oocyte quality, and endometrial receptivity. If you attend to all of these, use Doppler and 3D, you can improve the outcome of your fertility practice. Thank you very much indeed.